the song.
Ladies and gentlemen, welcome to The Wolf's Den. My name is Mark Ottobre, and in this episode we're going to be deconstructing the world of health, fitness and performance and exploring all things personal training. My guest today is probably one of the world's most sought after physiotherapists and rehabilitation experts. That's Dr. Andrew Lock. If I just read up a few of Andrew's achievements, he's accredited in the McKinsey Spinal Method. He completed his master's degree in 2004 studying the resolution of intervertebrate disc injuries. He's a conveyor of the Australian Strength Scientists Association, the coordinator of the Ultimate Strength Summit at the Arnold Sports Festival, an IFBB Pro League judge, a current bench press Australian and world record holder, and the owner and founder of Functional Strength Rehabilitation, which he has clients from all over the world participating in Major League Baseball, MMA, you name it, sports, clients that probably can't even mention on camera because they're that famous and that well known. So I've known Andrew for over a decade and he's always been my go-to guy for the world of health, strength and performance and rehabilitation. So it's an absolute pleasure to welcome him onto the Wolf's Den. Let's welcome Andrew Lock.
Good to be here. The big fist bump, Dr. Mark. Into it, yeah.
Alrighty. Well, first question, this is the moment of truth, Andrew. What do you bench?
Benching currently 200 kilos. Now I've got to do that next week in the comp.
Right, so have you benched 200 in comp before?
Not in the comp. I've missed it 4 times in the comp so far.
And what's your best bench in training?
Oh, in training, back in 10, 15 years ago, it was 230.
Wow.
But I was just having fun because 230 was something I wanted to achieve. But now doing it in the comp's a very different style of approach.
And have you always had an affinity for the bench press, or is it like the lift that you've decided, I'm going to master this lift over the squat?
If I can lay down and do an exercise, you got me,
Touche.
Bench press is made for me.
Touche. Alrighty, well now that's out of the way. We've got the important stuff out. We'll start. So I suppose let's do the origin story and start there first. We'll jump all over the shop in this interview, no doubt, and as we unpack Andrew's great minds. But tell us, how did you get into physiotherapy? What was your starting point?
Could probably really blame Arnold Schwarzenegger for that one, I think. Essentially, I started my life thinking I was either going to be a professional wrestler or I was going to take up professional baseball. I played for Australia as a junior. And I was getting prepared to go to the States to play. And somehow I just saw a muscle magazine with Arnold Schwarzenegger on the cover and thought, that's it, I'm going to do the next Conan the Barbarian movie, right? And I thought, I better go back to university while I'm doing that because this might take a little while. So I still haven't made one of the movies yet, but 20 years later, I'm still a physio. So that's where it really took me because, as a physio, I had an affinity, I suppose, more as a baseball player to being injured all the time, throwing high velocity balls and things like this, and constantly seeing physio. So as a profession, I knew a lot about, as in, I like this sort of thing, it makes sense to me.
And you've competed numerous times in bodybuilding as well, or is that
not never. No, you have to diet to do that.
No, but you've also seen a lot of top bodybuilders. And
we've like Tony Doherty, who you've met before. Tony and myself go back so far that I can remember him bringing out Brian Buchanan, who was Mr. Universe at the time, and we've probably seen all the great ones from the 80s onwards, and probably known a lot about even the great ones from the 60s and 70s. So when it comes to the science of weight training, I've read everything that possibly could have been published just growing up. So, I've tried every routine you could possibly do. When it comes to the book of mistakes, I've written my own chapters. I can tell you, I've tried everything in weight training and made up a few of my own. And that's why, as a physio, I know when people come to me, they tell me they've done something particular, I'll probably have a good clue about what it is.
So you're almost this walker of two worlds. You've got the hardcore trainer, bodybuilding, love the bodybuilding side, power lifter, expert, and all these kind of things, hardcore gym guy. But then you've also balanced it out with this super intellectual academic feats that, your mind reading the studies and really understanding them and being able to challenge a lot of the pseudo experts or even experts and hang out with that. So I suppose firstly, let's go into the how did you become a hardcore gym guy? What age were you? When was the first time you picked up a dumbbell?
It's tough. I might have been about 16 or so. I basically truly would say with myself, I've got a body image disorder. I wake up every morning and I see myself as small. I go to the gym to get bigger. It really is, it's that sort of thing. I'm never going to be big enough. So that's been really, I think, one of the driving forces is an underlying look at myself and saying, physically I don't feel I'm satisfied with my strength goals or my size goals. And intellectually, I'm still pursuing my intellectual goals, is trying to put together the most complete understanding of the biomechanics and the sciences of lifting and the sciences of injury. That's my consuming passion.
When did that affinity for, I suppose, academia, where did that kick off? I mean, was it always, I'm fascinated with the human body, or was there a trigger to say,
There was definitely a fascination with the human body. Through high school, I definitely never tried hard enough. I was more interested in playing sport. I was more interested in being a professional athlete than I was doing the study. It was only after I left that I came back and I decided there were big gaps I needed to fill.
So you played Major League Baseball? Or
no, I played for Australia as a junior.
Yeah.
Played in the Junior World Series in America, and that was really where I was seeing a career path heading.
You also played cricket too?
Yeah, I played cricket. I was selected to the Australian all-high school team as well. So, they were my sports at the time. But something in there changed, and I started to want to lift weights and get bigger. And that does not necessarily make you a better baseball player or a better cricket player. So those sports were going to suffer when I started to get bigger.
So was it due to injury that led you on the path to the physiotherapy, or like what was the moment that you said, this is what I'm going to dedicate my life to and be an absolute master at this?
I still think I'm still developing a long way from what I've got to be yet. So I would look at it and say those things are very unfulfilled for me. So intellectually, I still think there's a lot of things I want to be perfect at. And I think the sciences are very established that we're pursuing. It's just the universities now are doing a very poor job of educating health professionals. They've lost 400 years of research. They're going off in weird places. It's just the most strange, almost abdication of responsibility. So my work now is to help health professionals get back on the track of saying, the same science that launches a rocket to the moon by NASA is the same science you're going to apply to a deadlift. It doesn't matter what the random controlled study says. The random controlled study, if it conflicts with the fact that NASA puts a rocket on the moon and knows how to do it, well, which one's wrong? Maybe a random control study didn't look at the variables that should have been looked at. So that's where I find a lot of the problems with the current approach to things, are saying, what's the evidence base? The evidence base actually is science. The research sometimes is so poor, that's not evidence.
Let's just get into that a bit. So for you getting into the world of physiotherapy, was there someone who I suppose you looked up to that thought, right, their body of work is very complete and that's what I want to kind of model myself as a physiotherapist and rehabilitation expert as?
No, it's very strange to think about. I initially went into it to think I was going to get answers. I think what had essentially happened was, by getting a degree, I realised that it just enabled me to start finding the answers. So the first stage was, I probably thought, after 4 years I'm going to be a physio, I'm going to know what I'm doing. After 4 years you come out and you go, well, guess what, you really don't know a hell of a lot, but you know how not to hurt people, hopefully. You've got a few biomechanical ideas, you've got a bit of science to start you off. What are you going to do? So for me it was saying, there's big gaps in my knowledge, I wanted to become the best spine guy. And one of the great pieces of advice I got was that most students, when they graduate, they went straight into hospitals, feeling that that was a safe environment. I had been asked to join a sports medicine group because I had played baseball and cricket and I knew how to throw, and I had some ideas on shoulders. So the first day of work that I ever had, the boss pulls me in and she goes, so your job here is to become the best in the world at something. And she looked at me and said, and I happen to be the best in the world at shoulders, so you're going to have to choose something else. And that led me on saying, okay, what joint am I going to look at? What am I less competent at? And spines. I thought that we were very deficient in spine knowledge.
So how old were you then?
Oh, I don't know. Good question. I'm still 21 now.
Okay, so you're 21 back then.
And 21 today.
When you say you're looking for answers,
yep.
What? Because I mean that's quite an interesting topic. What answers were you looking for? Answers to what? What was the question?
A person who would come in who had pain in their back. How was I going to get them better? But not only how was I going to get them better, how was I going to know that what I was doing was going to get them better? So 80% of all back problems get better in 4 weeks regardless of the treatment. It doesn't matter whether you come down and the guy slaps a fish over the top of your head 5 times under a full moon, for the physio sticks, dry needles in your butt, the osteo stretches you, the chiro cracks you. Basically the statistics are straightforward. Human bodies heal. So human bodies are going to heal, and it's got less to do with the practitioner in those first 4 weeks than really just your body doing the work. 92% of back problems are basically better in 8 weeks. Now to me, that's not sufficient. That just means that you're basically a babysitter. You've got to know, how do you get 100% of people better? How do you beat the tough cases? I love the ones that come in 10 years of failing with everybody. That's the one I want to see. Because I know there's an answer underneath there. So it's a burning passion for me to never accept anything less than 100%.
But what prompted you to ask that question in the first place?
Funny enough, I think there's a pride issue. I think that there's an ego issue underneath there, and a belief that I should be better than I am. So it's always fulfilling something. It's always not believing that I'm good enough. And of course I'm not yet. Haven't benched what I want to bench, haven't lifted what I want to lift, too high in body fat still, intellectually still doing really well, but there's better answers out there for the occasional case I'm still having challenges with. I'll still get someone close, but I want to aim for perfection. So that's the constant goal. It's constantly polishing and refining. Doesn't matter what an exercise is, doesn't matter what the diet is, I've still got to work towards it.
Now, would you describe yourself, and this is kind of an open-ended question for a purpose, but would you describe yourself as a regular physiotherapist?
Hell no. I'm the only one who does what I do. So I actually don't even like being, in the respect, saying actually I'm a physio, because I think of myself as a health professional, a scientist. Now, there's no difference to me between the professions of chiropractors, physios, osteos, myos, exercise scientists, exercise physiologists. It is the person, not the profession, that matters. If the person's got a burning desire to do what they're going to do, they're going to be the person you want to see. You don't want to see somebody who says, I'm a physio, therefore I ignore chiropractic, I ignore osteopathy, I ignore exercise science, I will only do what physios do. You do that, that's lazy. It means basically to me that you're not going to become really good at finding the answers. There are answers in all the professions, and I'm trying to bring them all together. That's one of the things about the Australian Strength Scientists Association, which I'm looking for, is we're going to just bring everybody together under one banner which says we all have one burning desire to be the best we can as scientists. And that's much more important than being a physio. So yeah, if I bill it under a physio code, but reasonably I'm the only one who does what I do. They don't teach biomechanics of the spine in universities for physios.
So for those who are watching this maybe on YouTube or Facebook, you say you're the only one who does what you do. Can you define what you do? How is that different?
Well, the thing about it is too, there's other practitioners who have come to my courses who are also on the path that I've been on. So I would say in that respect is I'm the one who's at my point in my career, but there are some really good physios, chiros, osteos, exercise scientists, myotherapists who have been to my courses and work thinking the methods that I've taught them and are learning their own things and are on their own journey the same way I was. But as physios go, what I do and what I teach physios is not what's taught in universities. So way back in the 1600s there was a fellow called Borelli. Borelli wrote the first book on biomechanics. He called it Iatrophysics. Now he started to apply just basic lever systems, torque, rotation, weights, as applied to bodies in motion, whether it's animals or humans. Now, this is the basics of science. We know these things are real. There's no need to do a random controlled study on basic science. So when I look at what he started with, and I look at the evidence that especially comes after that, whether it's the physiology of, you can look things up like Lord Sherrington on nervous system, way back he got his lordship for that. There's a lot of basic physiology we understand. I think the physiology is not well understood by physios, because you should look at length-tension relationships of muscle, you should look at force-velocity curves of muscles. You should understand how systems work. And they don't teach us in physio, as far as I can see, according to what I'm hearing from the physios who I've been chatting with. So then I look at, say, the evidence of spine problems, which starts really very, very well back in about the 1930s with the first important, study published on disc injury. And after that, you'd have Robin McKenzie's great work on understanding how discs are influenced. There's no question about what he said. There's no question about his approach to diagnosis. It works for the right person. Everything's a tool in the toolkit. Now, there's professors now, Adams, for example, who you can look at his studies. His studies support what McKenzie does. It shows how discs are influenced by different areas of pressure that you put the body into flexion or extension. But physios are saying, oh, we don't have a random controlled study for this. You're missing the point that the science is actually already established. The biology, the physics is already there. What are you looking for when you're saying there's no established lifting pattern that proves itself better than anything else in a random control study? Well, that's because you haven't looked at the personal anthropometrics of every single person you put in that study. What's their femur length? What's their arm length? What's their hip socket like? All these things are going to influence how a person lifts. But if you just put a study together of getting 10 people in and say, looking at deadlifting, you're going to get 10 different deadlifts.
So would you say the field of physiotherapy at the moment the big difference between what you're doing and say what's being taught at university is the lack of understanding or acknowledgement of the science that's come before. Is that
spectacularly so? What really horrified me the other day was I found out there was one of our greatest ever physios as far as a manual therapist goes, a guy called Jeffrey Maitland. He wrote two books on manipulation, on approaches and thinking and how we look at spinal problems. Jeffrey Maitland came from the University of South Australia. I think he was a World War II fighter pilot. Brilliant mind, great techniques. So we always looked to the University of South Australia saying this is where Maitland is at the time, he's dead now. People who went there to learn from him, it was tough. He was very, very specific about how good you had to be. After him, we still followed his approach. University of South Australia, we're told, doesn't even mention his name anymore. They're running pain science, which means, hey, guess what? There's no evidence for the way you have back problems. It's all in your head. You're scared of lifting. What the hell has happened to 400 years of solid science? Great educators. Oh, we don't even talk about that anymore. Published studies are ending up in Lancet, the English Medical Journal, which have no biomechanical input, but are all written by people who don't talk about biomechanics, who talk about, hey, guess what, 70% of problems, we don't know what the answer is. Well, maybe you don't, but there are other people in the world who do and are far better at assessing back problems. But in Australia, we tend to push Australian things. So we've got a bit of an intellectual black hole occurring right now, where we're ignoring the work of Professor McGill, who's published over 240 scientific studies, published 5 books. No one knows more about the biomechanics of spines than Professor McGill. You won't find his name mentioned at an Australian university.
What do you think happened there? Why is this rejection of science by the Australian, I suppose, rehabilitation medical professions?
I think it comes down to politics about what funds a university is funding studies that are Australian, for example. So the transverse abdominis multifidus fiasco that occurred back in about 94 onwards, just trying to remember the perfect date, we all ran with the idea that there was this forced couple between multifidus and transverse abdominis. It isn't actually a forced couple, it fails first year biomechanics. They are not a forced couple, it fails that definition. But it was written by the professors at Queensland University that it was a forced couple. It then allowed the Pilates phenomenon to take off because they said that validated how they worked. Now, everyone's saying basically that was wrong, but it was evidence, it was Australian. So because it's Australian, everybody taught it. It was wrong.
So is this kind of presents an interesting issue for, I know, personal trainers, strength coach and people with back problems all over Australia, is should we be very distrustful of our rehabilitation specialists? Should we be distrustful of the physiotherapists that we're seeing because the education is subpar? I mean, I suppose it's a twofold question. Should we be distrustful, and then what do we do when we're injured? Who do we actually turn to if not you? Because obviously you're one guy.
The challenge is, realistically, is that as professionals, we've got to become a little more solid in our understanding of the true basic sciences and look to those before we start wandering away into what study says what. We need to know our physiology outstandingly. We need to know our basic biomechanics. We should know pretty much straightforward assessment techniques. That's pretty straightforward science. It's not tough. It just takes a bit of work, a bit of application, and I think most health professionals are capable of doing that. I think that's really important, is basically we need to just find more health professionals who are separating themselves away from what's been taught and saying it's not good enough. We need to be better.
So what does the average trainer do, right? So, or not even average trainer, what does a great trainer do? A great trainer, they have a client, they're like, yep, this is out of my pay scale, there's stuff here that I don't know. Client says, this has been a problem for me, I'm gonna go see a physio. They go see a physio and they get some, no, that's in your head, your trainer doesn't know what they're doing, go do some cardio equipment, and then that person ends up worse. What's some practical advice?
See, well, I think the practical advice is actually that the trainers need to talk to the health professionals in the area. It doesn't matter whether it's an osteo or a physio or a chiro or an exercise scientist or an exercise physiologist. You got to say to them, so how do you treat a particular problem, whether it's a back problem? How do you treat a shoulder problem? And if they say, oh, we dry needle this, we stretch that, I'm just thinking that person doesn't know how to assess something. So I'd say to the health professional, or I'd say to the personal trainer, I'd say, ask the health professional who you're going to refer to, do you personally deadlift? Because if you don't personally deadlift, I'm not sending my clients to you because you don't know what I do. Now, I would say the same advice to someone who played tennis. If you're a tennis coach, I would advise that any health professional you see, you would say to them, do you personally do my sport? That's a great start. Have you personally got experience in my sport? That would be a useful start, because that person then has probably got an affinity to it. So I would never send to a generic professional. I would, as a health professional, say, do you know what I do? If you don't, do you know someone who does? So there's some good physios out there who I know who are powerlifters now, and bodybuilders, and chiropractors, and osteos, and exercise physiologists. So that's really important. I think there's some good professionals out there who are embracing strength. And that's essentially what we say. You know, my mantra is weakness cannot be tolerated. You know, strength solutions to problems.
What do you think currently is the biggest myths or biggest myth in the physiotherapy realm?
The biggest myth currently would probably be the concept that there is such a thing as non-specific lower back pain. So we often see this put in a study. If I see a study that says non-specific lower back pain, don't bother reading it. It means that the person cannot assess the problem, doesn't know what the direction is, basically hasn't got an ability to say whether this problem has got a flexion or an extension intolerance, whether it has certain characteristics. It just means you put everything together and you did a study. If you have a study, if you have a person who's flexion intolerant, you can hear from their subjective, you can look at their objective, and you get another person who has an extension intolerance. But you can't find on the scan something on either of them. It gets lumped together as non-specific lower back pain. Now, if you give that person those two people exercise intervention, one into flexion, well, one of them's going to get better, the extension intolerant probably. The other one's going to get worse. Vice versa. Your study comes out 0. It's because you put everything together. You didn't properly define each individual person. And that's where this idea of non-specific lower back pain doesn't exist. There's no such thing as non-specific lower back pain. There's always a specific to a back pain. There's always an answer.
It just kind of means that they're not educated enough to find the answer. So
100%.
It goes to someone who
that's
needs...
it. And if you've got people at the tops of universities who say that 70% of them, they can't understand what 70% of the pain is. And that's one of the professors that I saw who published said, I don't know what 70% of my back pain problems are caused by. Well, that person's supervising studies by undergraduates. That's horrifying. That means that person's going to be just running studies in the same intellectual vacuum that they have.
It almost seems that universities are almost being offended by the facts in a way to keep a political correctness, not to offend people and say, no, this is not right, this is good, and which is quite a sad state.
It's a bad thing. Basically,
academia.
Basically, I think a big thing against is they're not acknowledging that overseas are actually better than us.
Who do you think overseas-wise, all over the world, who do you think produces the best rehabilitation specialists?
No doubt at this point, Professor Stuart McGill, most progressive individual, the most experienced individual. As far as I remember, he spent over $500 million in research money at least on work. No doubt the person who I would approach from the most open-minded, philosophical approach to science.
What's been some key takeaways for you from the work of Professor?
To examine everything, to basically test your hypothesis. You find a finding, apply an intervention against it, reassess your intervention. Basically what I learned, even as I learned from the Maitland system, that's what we did then. Apply an intervention, assess. Is your hypothesis right or is it wrong? If it's wrong, change your hypothesis.
What's a hypothesis that you've believed for years, and then applying this kind of thinking, you've proved yourself that actually that's not so? Has there been something that springs to mind?
Not so far. It's looking pretty good. Basically, by the time I've got a hypothesis, I've got a good reason for it.
Yeah, awesome.
So within a session, sometimes I go, that didn't work quite as well as I thought. Perhaps if I unload it further, it might change, or perhaps I increase the load, it may change. That's probably how I have to go. It might be a load choice. So if I'm looking at a person's QLs, I might have to look at a way of, maybe the side plank didn't work as well as I thought it would. Maybe that we'll do a suitcase lunge and see what that does. And basically, maybe that involved then some glute. Now I've got to look at the glute involvement then. So basically, it's like an evolving thing. If I'm doing an assessment, I'm evolving within the assessment. And the big thing about that is, I can take an hour for an assessment at least. Professor McGill is well known for taking a whole day on a single patient to find out the tough ones. Now, you walk down to the local, as I call it, sausage factory, and you're in there and the physio chucks some needles in your butt and heads off to the next room, or puts a hot pack in your back and heads off to the next room. Well, he goes to the next room, the chiropractor lays you down, cracks your back and you're out in 5 minutes. Hey, there's no assessment, there's no reassessment, there's no science behind it. It's basically, I'm under time pressure, I've got to sort of figure out how to make this work. That's an old model that I think should be basically banned. And all the good chiropractors I know would say the same thing. I've got a great neurosurgeon I know in Perth. Now he sends his clients to a chiropractor for rehab. His chiropractor knows how to deadlift. Well, there you are. I reckon it's a great chiropractor. It's not the profession, it's the individual.
So let's talk about a slightly different topic, but still on the lines of myths and misconceptions, and that's Pilates and Joseph Pilates.
Yeah.
Can you give us your thoughts, and I suppose what happened in the Supreme Court?
Yeah, well, basically the problem which I found with Pilates was that he died in about the 1960s. He wasn't a scientist, he was a creator of things to sell. Basically, if you look up, you can probably find a lot of interesting wacko things he created. The reformer just happens to be one of them. And when he died, a lot of different students basically determined that they thought they knew his system well. So as it goes, it mutates. And someone decides they want to trademark the Pilates name, so it ends up going to the Supreme Court in the US, and the Supreme Court basically says, you know what, there's so many different versions of Pilates, we can't define it. We can't say that this is the true Pilates, basically no one can trademark it. So it becomes this open thing where I can walk my dog and say I'm doing Pilates. I can brush my teeth and say I'm doing Pilates. No, there's no Pilates international body that says, no, that's not wrong, this is a series of things that we do. And unfortunately, I think when the transverse abdominis multifidus thing came out, the Pilates people said, hey, this validates what we do. We pull our belly buttons in. Well, the bad news is, of course, that's now been proven to be dead wrong. So it invalidates the Pilates that was doing back then. But Pilates now morphed into a new thing. Fortunately, there's a health professional I know who's sort of looked at the same problem, and he's a bit of a Pilates advocate. And he sort of looked and said, yeah, what we've got to do is we've got to say, I like the reformer, but I'm going to set down a standard series of exercises, movements and assessments using that reformer that will become, under my name, a standard protocol. Now that's what Pilates is missing, it doesn't have a standard protocol. So you can go to 10 different Pilates places and get 10 different things. But if you set up a serious protocol on the reformer as an exercise piece of equipment, I'm happy to say that you're a scientist and you're starting to make some evolution, you're starting to get rid of the rubbish. So that's the problem with the Pilates thing is, it's like saying yoga. Is yoga good or bad for you? Depends on the practitioner. It could be good, it could be bad.
So essentially, everyone today pretty much watching this, if they're owning a gym or a personal trainer, they could say, yeah, we do clinical Pilates.
You could, no one's going to be able to stop you.
Yeah, and be then deadlifting heavily and, the squat bench. And
call it Pilates, it's fine.
Yeah, it's also, yeah.
No one can stop you.
All right, interesting, eh? So kettlebells have, in some regard, gotten a bit of a bad rap by particular strength coaches and I suppose the industry in general. Sometimes people just don't know how to use them. So, the kettlebell swing, let's start with the kettlebell swing first and kind of unpack kettlebells.
Yeah.
But kettlebell swing, good or bad?
Depends on the individual, depends on the problem. So there's no such thing as a bad exercise. There basically is just the wrong exercise given to the wrong person at the wrong time. That exercise might be great at the right time, but at that time it's the wrong one. So one of the studies that was done very well, I think it was McGill's study, looked at a particular style of kettlebell swing, and when you add up the mathematics, you basically pull things apart. It's like, you're basically looking at how forces are occurring in the body. So he found out that the net effect was that there was a posterior shear on the spine with a kettlebell swing as a particular style he used. Now, is that a bad thing or a good thing? Depends on the person you're going to apply it to. There are certain people who a posterior shear force, which is just how the muscles will work, will actually make that person better. They were deficient in that posterior shear. That's something they needed. They needed a balancing force to an anterior shear. But you've got somebody else who the posterior shear is not going to be very effective for. It's going to make them worse because that's actually part of their problem. So you've got to know whether it's a posterior shear problem, an anterior shear problem, and the kettlebell's fine. But I'll show you how to do that later.
So on that, is the kettlebell a mutually exclusive rehabilitation tool? Is that how practitioners should be looking at it, as it's not really a tool for anything else?
I think you could use it for anything. Great conditioning. You could use it, I use it for teaching lifting patterns. It could be used for any version of almost any exercise you want. You just have to get some damn big kettlebells sometimes. I go up to 92 in my clinic at the moment for kettlebells. Well, if you can deadlift more than that, well, you need to move away from kettlebells if that's your goal.
Something you taught me a while ago was you should have phases in your training: practice, train, performance. And the problem with a lot of people is they don't have any practice phase. They don't learn the movement patterns. They don't learn the lift. They just go into training, or worse, they go from basically what they should be a practice phase into performing. And you see a lot of 1 rep numbers when they really shouldn't be, because the movement. So how long would you in your clinic, would it take to say someone says, you know what, I want to be an Australian deadlifting champion. How long does it take to grind a good movement pattern to then say, yep, you've done practicing, let's go into training?
If you want to get to reasonably in a federation that has got well established, not a new one that started last week in the backyard and you can get a world record from, if you look at really established great federations, it should take you at least 3 years to learn the skill of how to perform at that deadlift, squat, bench press. And at that point, if you've been training consistently, and I would say that means no less than 3 times a week on the lift that you're trying to do, I don't mind if it's 7 days a week you practice, then I would expect it would take about 3 years for you to have a 1 rep max that I would probably feel that you're going to be safely performing without changing in your technique. So that's a lot of work to be done. Some people, it may take a year, but then again, you're looking at biological tissue under stress. It can take a lot longer than 1 year for your bones to know how to handle 150 kilos. You might be able to physically do it, but you may not be doing it in such a way that's actually beneficial to you as a person, that your bones may not be accepting it. You may need a little bit more time to, time off, time to recover from the heavy sessions. There's a lot to it, the biology of recovery too. So I would say technically you can practice every day, but you might practice at 50%. I'm going to do a bit of bench press here today. I'll probably go up to 50% just to practice, because I compete next week.
And you've seen that certainly in your practice, people who have been quite proficient at lifts, broken bones on, say, a bench press, you know, snapped humeruses and all kinds of issues. You know, I've certainly heard the war stories and seen that, which have been pretty nasty. And you look at some of those people and you go, well, that shouldn't happen, but it does. And that's just simply because the adaptation on a skeletal level just hasn't happened. That
would probably be it. For most of those, that would be the best explanation we'd almost have for why a bone has broken under a load, because it hasn't adapted. I know that if you look at the bones of people who have been in you know, some of the institutions in America for 40, 50 years, who've been lifting weights, and you look at their cadaver bones, they're pretty solid. They're like whale bone, because they've been lifting weights for the last 40 years and they have adapted. They're solid. There's positives and negatives to that.
So I think you've mentioned before Bev Francis.
Yeah.
Would you say she was very good at understanding the practice, training, performance kind of thinking style in terms of her training? Because she trained the same lift almost every day.
Well, the thing about Bev, who's in my mind perhaps Australia's greatest ever athlete, if you really want to have a look at the history of Bev Francis, you can look at somebody there who, she actually, it was interesting because I chased Bev for a while because I always wanted to know how she set the Australian bench press record. I think it was 150, I was trying to remember what it could be, 155 I think it was. And I stood for 34 years. I think she looked at me and thought I was a stalker because she used to run away, but one day she had to sit next to me on a judging panel. And I finally turned around and said, Bev, so how did you bench the 155? And she looked around and suddenly realised I actually had a question I was supposed to answer. So Bev said, bench press, squat and deadlift 7 days a week. We got chatting and I said, you benching 150 kilos as a female, seeing the world record, I said, that was like Roger Bannister breaking the 4-minute mile. And she said, yeah, we both had the same coach. So there was a coach who knew how to create top level athletes. And his approach was, you practiced every day. So it didn't mean you busted out max singles every day. But if it was Monday, it might be a big bench session. Tuesday, you might go in there with 50% of the weight. Work on your technique. It might be a day when you're doing squat training. That's where you did your hard work, but you still practice your bench and your deadlift. Maybe that's why she won as many world championships as she did. It's the fact that practice creates better neurological patterns if you do it right.
So is this how you structure your training now? I mean,
yeah,
you
very
bench
much.
Every day?
Yeah, bench every day.
Yeah.
I mean, not massive amounts, but within a cycle and a program. And out of the program, I put my hands on the bar every day and set up and try and find that groove. So even last week, I actually found a whole new cue I'm going to let everyone know about today.
So on that, let's say your max is 200 kilos on your bench. Do you have a structure of your week of like, okay, Monday's going to be max, Tuesday's going to be 50%? Like, is there a reason or rhyme? Is there a structure to it, or is it?
There is, and I'm not a programming scientist, so I allow programming scientists to help me. So I will ask someone like, Gus Cook in Queensland, who's very good for my powerlifting programming. Sebastian Oreb, coached the world's strongest man. I ask him for advice as well, so we work together. So I don't program myself, I practice myself.
Is Sebastian a train every day kind of guy? Is it in terms of the programming that he recommends?
He practices every day. No doubt, and you can see the results. No doubt. There's a guy who pisses me off greatly. He weighs about 40 kilos. Weighs 110 today, and I'm 135, so he's 25 kilos less than me, and outbenches me by probably 40 kilos. Yeah, fantastic athlete.
What do you think the worst thing that someone could do for their when I say back, I'm really talking about lower back, and I suppose lumbar spine, but what do you think the worst thing someone can do for their back?
Well, the worst thing you could possibly do is keep doing the thing that you've always done that has caused you the problem. That's the classic one. So someone hurts their back and a professional says, okay, rest it for a few weeks. Okay, you rested it for a few weeks, now you go back, you're not feeling in pain. What have you done different? You've changed nothing. Definition of insanity. Do the same thing, expect a different outcome. So the worst thing I think anyone can do for a back problem, keep doing whatever you've been doing, because there's a problem with it. Find out what that problem is, make a change. Rest is not what you ever do. You've got to actively figure out, hopefully under the guise of someone who knows what they're doing, usually a biomechanically educated professional who's seen me at least, and learn and find out what is it about you, what you do that's been hurting you. Stop it. That's usually one of the great things about it is I get people who come and see me who have seen a lot of other health professionals, and they show me what they've been doing, and I just say, well, if you stop doing that exercise somebody gave you, you'll feel better. That's the reason you've got a problem, is you've been doing that exercise that somebody else gave you.
What's a common intervention that you would give for back pain?
Common, but usually as we look at it, the problem is people sit most of the day. So obviously there's a form of flexion. They tend to sit in posterior pelvic tilt, not anterior pelvic tilt. Anyone who says that is really lost the plot. Yeah, anterior pelvic tilt's so rare, it's phenomenal. And every single person in this room right now is sitting in posterior pelvic tilt. You don't have an anterior pelvic tilt problem. So posterior pelvic tilt is a form of flexion. You're going to sit in that for a whole long period of time, and then you're going to do other flexion work. Well, there's the problem. You're not extending. You're not balancing out your flexion forces with your extension forces. I have a rule that says you should put every joint in your human body through its full range of motion once a day. That's pretty important. If you do that, you probably won't get the rust accumulating. So that's a bit of a philosophy approach I take. So I take that to the spine. If you haven't been extending, you should extend if it's appropriate, because guess what? Every rule you will ever make, there will always be an exception to. There is somebody out there who should not extend. And it's going to happen. You just got to know how to identify that individual. And I don't think it's that hard to identify. There are people who need to sit in flexion. Guess what? They're pretty rare, but they'll be out there. So there's no blanket rules ever going to apply to everybody. The day you make a rule, next day someone's going to walk in and break it on you. I did that with deadlifting. I spent a couple of years defining the physics of deadlifting, and I had it all figured out. Just the day I'd figured it out, guy walked in who broke my rule. He had to actually bend his tibias forward to actually get to the bar. His torso was too short, his thighs were too long, his arms were wrong length, hip sockets were too deep. And guess what? You just broke my rule. And don't ever deadlift and don't think you'll be a world champion because you've got everything wrong with you.
Wow. What I'd love to do now is, again, just to give the viewers at home and everyone in the audience a real insight into the way Andrew thinks, is to get someone out. And I'm thinking we go for Adrian and get Adrian up. Let's give Adrian a round of applause. He's one of the great trainers here at Enterprise. We'll use this box so you can see it. We've got him in position and you can see what's going on. But would you be able to
sure, tell us whatever you want.
Give a bit of an assessment and demo? So Adrian, is there anything wrong with you besides the obvious?
Have we got any physical problems?
But if you get to have a client and you've got a client for the first time and they come in, run us through the way you think about things.
Oh, it's a long process because I take at least 20 minutes to talk to the client. So one of the first things I say is, Adrian, what problem do you have?
Yep. Oh, well, mostly I get tight traps, big problem,
yep.
And this tight hip kind of leads to sciatica pains.
Now, interesting is, where's your hip? Show me the hip. Mm-hmm. All right. Now, if we were using the back of the hand, I'd say to myself, okay, so we've got a different version of what the hip is. But if we're using more with the thumb, I'd say we're getting pretty close. So it's always important, I find, to get the person's anatomy defined with your anatomy, because somebody says hip and they point to their knee, okay, we've probably got lost because we've got two different versions of what a hip is. But that's okay, now you've pointed to it, I know what you're talking about. Now one of the problems I'd always get here is a couple of times a week, if not a day, I'm going to get a person who comes in and I'm going to say, so what's your problem? They pull out a scan and say, I've got an L4-5 disc bulge. I'm going to say, no, that's a diagnosis. I just asked you what your problem was. Because the thing is, what is the person's problem? I don't treat a diagnosis, I treat a problem. So when a person says, I've got shoulder bursitis, I didn't ask what your diagnosis is, I said, what's your problem? What can't you do? What gives you pain? Now that's the super important part for me. So when you want to know how I think, this is how I think. I want to define what the person's problem is, not what diagnosis they've been given. Because people sometimes possess diagnosis, and I don't want to possess a diagnosis, I want to understand a problem. So I start letting the person know I'm actually looking at what are they feeling. A lot of times they've had problems with professionals who come in, they'll put a scan report down on the table and the professional will read the report and suddenly that's doing everything. Anyone walks in to see me with the scans, I tell them to put them on the table or put them under the chair because we're not going to look at them until I've done everything I can do, then I'll look at them last. The whole idea is to be totally clear-minded and see a person as a new person. Someone will come and say, oh, I've got my last physio's notes. Good, put them away, I'll see them last. I don't want to know what anyone else has thought until I've seen you. So that's the sort of approach I tend to take. So if we came back and said, this would take a long time because I would go, okay, so you get a sciatica thing, how do you define sciatica? What do you feel? What is that for you? Where do you feel it? For example, I would say, because we're not going to be able to go through it, it'll take an hour or two. I'd also say, okay, so when do you feel it? When you're doing what? What makes it feel better? What makes it feel worse? We go and pull all these things apart. So I've got an idea about what forces a person has a problem with. And then I'm going to ask things like, whether there's a constant nature to it, whether there's an intermittent nature to it. I want to know whether there's an inflammatory component to it. I want to know the history behind it. Basically, there's a lot of questions. It would take me probably 20 minutes quite easily. Sometimes someone walks in and I've got it probably within 30 seconds, I know what their problem is. But I'll still go through all the questions just to make sure I haven't missed anything. And I'll teach you a lot of those questions today as we chat through. So what would we like to look at today, Mark?
So I think what we're talking about, which is one of the common interventions that you give, which is the back bend.
Yep.
Maybe we get Adrian to demonstrate where he's at.
Well, it depends, Adrian. Do you have problems sitting, standing, walking? What tends to be your problem?
It's also when I'm not moving. That's when it gets really tight.
Yep.
And I find that I can't. When I shift out, it feels like it shifts. If that makes sense.
Yep, sure.
Kind of it feels like the muscle's shifting over there.
All right. We could do a fairly quick style of approach of a test for Adrian, right? So you've had no diagnosis of any strange conditions?
No.
Great. Well, whip off the Wolfpack top there. We just want to have a look at a movement pattern. As Marcus suggests, we had a nice time sitting down for a while. Show me how and far you can go bending forward to touch your toes. All right, so
touch
there.
Just stand up on the, so everyone can see. Stand up on the box. There you go. Perfect.
Yeah. And face me. Good. And just do your thing. Bend forward. All right. And come back up. So what I've looked at there, at this point, because I'm standing in front, I just looked at how far he went, okay? Now, normally I'm going to actually look at how, I'm going to have his shirt off, and I'm going to look at how he got there, more importantly. But because we're going to look at flexion extension for a moment. Okay, so put your feet a little bit wider apart for balance so you don't fall off there. Put your hands on your hips and bend backwards. Good, that's fantastic for about a 75-year-old. Okay, I want you to do that 10 times now, bending backwards, and each one I want you to go a little bit further back. Hips go forward, shoulders go back. Mark will catch you. So hips go forward, shoulders go back. That's a bit better as far as the movement goes. Yeah, he's getting about 60 now. Hips forward, shoulders back. That's it. This is a very passive movement. Basically, this is lumbar extension. We're placing his upper body's centre of mass behind the disc. This is the basic concept I'm looking at here. Hips forward, shoulders back. Let's at least turn you into a 50-year-old, could we?
If you wanted to explain what was happening on a...
Yeah, we'll have a go.
Yeah.
Now, come on, can you do better than that, seriously? Yeah, come on. Give me two more.
I'll just repeat the question for the audio, and that's, Andrew, how far would you want them to go? What's the gold standard?
Probably age appropriate. How's that? So, as I said, if he was a 75-year-old, that would have been acceptable. Okay, now bend forward and touch your toes again. Let's have a look at what you got. Do your thing. All right, it increased slightly, didn't it? Was it easier?
Yeah.
Now, what happened? Why is his flexion increased, but we didn't stretch flexion, did we? Normally you think that to get further in one direction, you've got to go that direction. But he went the opposite direction to increase that direction. This starts to make you think about the way you do things too. Why is it that going one direction increases the other one, yet normally you would think that you'd have to go that direction to get there? Well, the concept here goes back to the 1930s, but especially 1972, when the great Robin McKenzie, whose work you can find and read his book, Lumbar Disorders, and you can get his own book called Treat Your Own Back, which is a really great, straightforward explanation. The concept is here, this is what our spine looks like in Adrian. Now, as he's been sitting doing that. Like a kid's party balloon, if you put pressure down the front here, disc fluid in the centre gets pushed backwards. So when he goes to bend forward, his spine's already a little bit forward anyway, and the disc pressure is up towards the back, and it doesn't really want to go there that much. All right, now as he then bends backwards, he puts pressure here, which causes the disc fluid to move forwards. Now as the disc materials move forwards, now it's centred. So when he goes into flexion, his body's not going to resist it. It's going to say, thanks. I now feel better. I've got more movement. The pressure's off and centred to be normal. So I took 10 movements there to improve his flexion. Now that's one of the things I might look at. All depends upon where my hypothesis is lying, because this is an objective. Now, I could put him through a series of stability tests now as well and find out, which probably would happen, is the more stable I make him, the more range of movement he'll have as well. So suddenly, without stretching, I made him tighter. And by making him tighter, he gets more range out of his body. So we use the concept here also then to say that proximal stability unleashes distal ability. Thank you, Professor McGill, for that, because I think he should have the t-shirt. I think he said it first. And it's the approach we take. I look at things from the passive tissues, which we just did then, and then I also look at the active ones. How do we stabilise? I'm going to take you through that today because that's really important. I'm going to teach you how to assess, basically understanding where the passive tissue insufficiency might come in and how we might use active tissues to make up for that. This goes back to a research paper and book written by in Punjabi and White in about 1984, which is called neutral zone theory. So it's not really a theory as much as evolution is a theory. It's like saying it's a construct of fact. So we're going to look at how neutral zone theory affects the way that you train, how you affect a back problem. Thanks, Ed, man.
Let's give Adrian a round of applause. So I know that you've said before with the back bend, some people it's like, oh, you know, you're not auditioning for Cirque du Soleil.
Yeah.
So I suppose just coming back to Reese's question of, you know, what is a gold standard? Appropriate range, yeah, for depending on the sport. Like, is there a...
That's a good way of putting it too. What is that person's requirement in their activity? How much extension should they need to have? So if I have someone from Cirque du Soleil who's a contortionist, I better make them get to that full position. That's what they need. If I've got a tennis player, I know how much basically I should be working with there. When you analyse, for example, a tennis serve, you might look at it and say, okay, that's how much extension I should be expect to see there. That's an important thing too. So when you look at a sport, now if we're looking at, say, powerlifting, or looking at squatting or deadlifting, there's not a whole lot of extension I have to deal with there. But if they are lacking into extension, it may have had a big influence upon why they end the position they are. So I sort of look at it as what a healthy movement looks like to me. Having seen 75,000 patients, I've got a bit of an idea about where I would rate a person as per age effective. So we'll sort of look at that a little bit today as we go through.
So in saying all that, I mean, one of the things you touched on was, you go one way and then it increases range of motion the other way. Is it an oversimplification to then start to think on that line of thought? If someone does or experience lower back problem, there's probably the abs aren't working the way they should, therefore a good intervention should be basically training the abs. Is that a way to look at it, or?
Well, what we would do there is we would, from the subjective history where I'm talking to a person about what they do, how they do it, I will get a clue as to whether that is the problem. Then as I stand up and I do an objective assessment, I'll get a bit of an idea what their ab tone's even looking like too. Then I might look at a movement pattern and see whether that ab tone is actually working. So there are people out there who definitely, I mean, it's almost universal to say there are not a lot of people who would have a detriment to working their abs and working and understanding how to control their core well. But that also comes with the balance of saying their extensors and their spine have got to work. The QL's got to work. Psoas has got to work. Lats have got to work. There's at least 10 muscles there I think of as core. So I think a lot about 10 different muscles, but obviously when we go back to what are the most common areas of problems, weak abs, weak butt. Yeah, run into those two things, weak abs and weak butt. That's probably you're going to get better than your 80% success rate. You start hunting up those problems. And I think that's a good way for a health professional to go. Like what I was told, become the best in the world at something. Okay, pick a muscle, pick a joint, understand how it works, pick an exercise. Become really good at understanding that. When you understand the principles of that, you'll start to find other principles start to apply to other parts of the body very similar.
So deadlifts, which is a topic probably close to your heart and
Yeah.
a lot of people's heart watching this. It's almost paradoxical though when we talk about deadlifts, because on one side of the fence you have people shouting that deadlifts are bad, and if you pick up a bar, it's going to hurt your back, and put down the deadlift and how bad they are. And then on the other side of the fence, you have people saying deadlifts basically cure all, and they put up videos on YouTube where it's a completely absurd form, and they're shouting, as long as the bar stays close to the shins, you'll be fine, and deadlifts are safe. Just make sure the universal rule that the bar doesn't travel away from the body. And obviously they're both extreme perspectives, and they're both misguided in truth. So let's start there. I mean, what are your thoughts on the deadlift and kind of navigating those both extreme ends?
Yeah, look at it from the point of view of saying there is no such thing as a bad exercise. There's just the wrong exercise to the wrong person at the wrong time. It's not going to deadlift. I've banned 2 athletes from deadlifting. They don't need it for their sport. Their structures aren't right for it. Don't do it. The cost to benefit ratio isn't there for them. But that's 2 people I can think of. Now I see 50, 60 people a week. Over the last few years I've told 2 people they shouldn't deadlift. All right, that means pretty much everybody else I've been able to work with has a form of a deadlift that I may use within a rehabilitation pattern. Might not be a conventional, might be a sumo, might be a hybrid. Lots of parts to it. What's my rationale for using it? Well, I can use a sumo really well to drive somebody into learning how to use their glutes for another task. So I was working with a fantastic athlete the other day who does strong woman work, and she was working on keg lifting. Felt her hips weren't coming through well enough. So I just brought out the band, put her into a box squat on here, put the band around a conventional position, and worked on the glutes from there. Went back into the keg lift, fantastic glutes fired up. I started it with a sumo thinking, I want to get the glutes fired up. She's got the best hip range you'll ever find. That sumo wasn't going to work her in the pattern that the keg lift was going to work. So when I look at deadlifting, I look at it the same way. What am I going to use it for? Am I using it to rehab a back problem? Am I looking to increase the size of a muscle group that's there? Yeah, I can use it there pretty well. That person has a driving reason they want a deadlift. Good, then I must make them learn how to deadlift. But once again, as I said, I've met 2 people who I think straight away don't ever deadlift. Now, if someone came to me and wanted to be world powerlifting champion and they had those unfortunate genetics, I'd tell them to take up chess. This seriously is going to be a car wreck. That's not worth rolling the dice on. Pretty much everyone else I can work something into. But you've got to be honest with people too. Seriously, if you're not made for this and you're going to be taking on people who are biomechanically superior to you and have just as much drive and resilience and will, then they'll come through. So I love deadlifting. I think it's one of the most primal, normal things to do. As you just said, if someone says keep the bar close to your shins, that's the rule. Not for everybody. There's the problem. A rule has to be broken by somebody. And if you only understand the rule and you don't understand the parameters which break the rule, then you're going to hurt the one who the rule should be broken for. So there are some people, great, closer to the shin the better. Other people, get back over the midfoot. That's where you need to be, because their shoulder position may have to be better to get the bar forward. Their femur lengths might be the wrong femur lengths for that person to be close to the tib.
You've studied world record breaking deadlifters.
Yeah.
What's the pattern? What's the commonality that you've found?
Oh, the commonality. The thing about every world record I've ever seen really truly set, it uses a technique that no novice should ever go near. Because the whole point of it, it's like Formula One racing, okay? You look at the world record holders and breakers in deadlifting, their technique is very similar to driving a Formula One car. It's an edgy thing that you must have so much experience knowing how to control it. Now, you put a learner driver onto a Formula One track in a Formula One car, what is going to happen? It's going to crash, and it'll probably be pretty freaking horrific, okay? You have to teach a novice technician, a novice lifter, a whole different series of things before they will ever get to world championship levels. You got to teach them how to control lots of things, how to switch lots of things on, how to use everything before they will morph into, okay, now you actually got this, you're not getting injured. We're going to change the spine position. We're going to change the bar position. That changes. And that's my call is it takes about 3 years to go from put your hands on the bar to you got a hell of a good technique. So that technique that learner has to have, put on the L plates, make them safe, because they don't want to miss training. They don't want to be hurt for a couple of years, which can happen. You want to get them as a professional too. It loses you money if your client's not coming in to train with you. So it's really important. You get to the world champion, you'll find that, yeah, it's pretty close to a stiff-legged deadlift for most of the conventionals. Big spinal flexions. Yeah, but they can do that now. But don't do it to your novice.
So technically, do you think there is some overlapping things in terms of, I know you've spoken about vertical tibias with world record breaking deadlifters. Do you think that rule does apply? Or, I mean, I know it depends.
It's the rule that absolutely applies to setting world records.
But not for novice.
Exactly. With a novice, you may allow them to come forward while you have to learn to get their hips into a certain position or their back into a certain position, because that's where they've got to drive from. Then you can get their nose back later, once they've learned to safely perform correctly what they've got to do. So, you know, you've got to learn how to find your tension correctly. So, yeah, I can show you the world's best technique. It's great, but that's like watching a Formula One race and thinking that's how you drive. You know, everything changes for the novice. Make them safe, make them work. So as far as physics goes, a vertical shin is imperative to apply maximum force to the ground. Gives you maximum ground reaction force. That's a fact. And if you watch every video of the world record set, that's how it's done. So they will achieve that position. And they'll achieve it probably with a hell of a lot of spinal flexion as well. That's okay.
This is what I love about speaking to you and really talking all things physical culture, is because there's a topic that people are so dogmatic about, and you usually get this black or white answer. Here's the way it is. It's when you express, and just on this topic of deadlifting, it really is all the colours of the rainbow of yes, but it depends if. And I think
totally.
I really appreciate. I think everyone watching really appreciates the angle, and it's just great to see.
And that's how we don't get people injured, is accepting that everybody is different, and listen to find out what those differences are. Look to find out what those differences are. You know, people might, for example, say, I've got, short hamstrings. You probably haven't got short hamstrings, you've probably got tight hamstrings. All right, well, there's a difference between the two things. You know, realistically, most people can achieve the splits today if we're able to, make them unconscious and, stretch it out. Because the muscle length is there, but we have limiting switches. Our bodies have learned how to limit certain movements. And part of our work may be having to harness that tension better.
It's almost in the strength community and rehabilitation and personal trainers, people have identified themselves with certain beliefs, and they become very dogmatic because that's the identity and I suppose dogma that they put on themselves, and they have to portray this to the audience, rather than in terms of what you're saying is, well, there is no identity to begin with. It's just science, and let's look at that, and then from that our body of work we can then decipher and get rid of the identity kind of politics of this is who I am, this is how to relate to, and actually care and look after our clients in a
That's the problem with the health professionals. People becoming religious about being, I go to the physio, chiro, osteo, the chiro, osteo, physio, that's what I am. You're not if you really want to grow. You've got to evolve, you've got to be a movement scientist. Great, look for evidence from everywhere. But the basic thing is, the evidence of physiology, anatomy, biomechanics, physics, it's not arguable. It exists, it's well established and studied. Okay, grow from that. So yeah, look, I even open up my anatomy books that I used at university every week. I see things again differently just because I'm searching. So it's like one of my favourite things. Have a look at Gray's Anatomy, one of the biggest books there is, right, anatomy. Try and find me a VMO. No such thing. We could talk about that another time.
Just on that, you said something before previously. There's a chiro in Queensland, I think you said, that
Perth, yeah.
Perth, that you refer to. What's something that you look for in other allied health professionals, whether it be chiros or osteos? Like, Because there has been this baiting, I feel, from the chiropractic and physiotherapists where the two professions have never got along.
Yeah.
But here you are saying, there's chiros who now you communicate with and talk to, that come into your courses. So what do you think is a good I suppose, trademark of good practitioners like this, like chiros? How do they think differently?
Well, one of the things I found is that the chiropractic approach was very central to the spine was the cause of all problems. Now, look, we can not throw the baby out with the bathwater on this one. Okay, the original chiropractor himself, named D.D. Palmer, I think it was, okay, had some wacko ideas, said he learned his techniques from the spirit of a dead doctor in a seance, okay, right out there. The spinal problems were the cause of all disease, not, germs. Right, a lot of wacko stuff, but essentially when you come to it, the manual techniques started to be very good. And also the understanding was that the spine does affect other things. It certainly does. And they have some great evidence that, hey, if you've got a sore ankle or a sore Achilles, guess what? It might be because your lumbar spine's stiff. So they started very centrally. Physio's got a lot more, oh, your knee hurts, let's look at your knee. My approach is, for example, if a person comes in with a knee problem, is I look everywhere but the knee because I want to find out, is there something else that set it up? If everything else fails, then I'm at the knee. But I could almost say, I'm going to guarantee you the knee is painful because something else is a problem somewhere else. And if you only go to the problem of going, oh, that hurts, and the physio goes and pushes it and goes, does that hurt? And you go, yeah, that hurts. You just learn nothing because, of course, they told you it hurts. You want to find out the thing you don't know. You want to find a thing that doesn't hurt them, but hasn't been working, that causes something else to hurt. Now, to me, it's a bit of a chiro mentality there. It was saying, look to the middle, work your way downwards. And certainly that was the education I even got my master's degree. The physios were involved there was very much start from the middle, work your way out. And that was the teaching and the mentality that we were getting was find a thing you don't know. I was told when I was doing my master's degree in one of the hospitals, pulled aside by one of the people there and said, look, basically you're still doing what you know makes people better. Stop doing that, start trying to do the things that you don't know work. And that's a good mentality because I was there to learn and test things that I perhaps didn't believe in as strongly. And I now take that into my practice very much. I'll test something out that I perhaps might have thrown away and still test it if it's appropriate. So you've got to constantly become uncomfortable as a professional because being uncomfortable, being discontent with your ability and your mental understanding is going to make you keep getting better. So I'm never content.
So you've, I know I'm personally a client that you've rehabbed, but you've rehabbed multiple shoulder injuries through bench pressing.
Yeah.
Yeah, if you presented that, I suppose, to the average physiotherapist, I think they'd say, what? That's absolutely crazy. You're supposed to not bench press at all. So, how? Tell us about that process of how you figured that one out.
Movement patterning. So if a person has pain on bench pressing, for example, okay, it mightn't be the first session we're going to bench press as a rehab exercise, but I will pull the components apart and find out why they're getting pain with their benching, address those components with the end goal that the bench press becomes a technique that actually just makes them stronger and reinforces the pattern that will prevent their pain in the future. In other words, they're bench pressing wrong, something's gone wrong. They're not using a certain pattern, they're not using a certain muscle group. So then if I can use that muscle group into the pattern of bench press, I got my rehab and they're happy. So that's one of my approaches. Although that is the movement that they're hurting on, it's only because they're doing it wrong or something is missing somewhere. And then by the time I've got into 3 or 4 sessions down the track, probably the client and myself know exactly what I'm asking them to do, where the problem lies, and we can use it as a rehab method.
So I know people watching this, strength coaches particularly, might be familiar with some systems of strength coaching where you're looking at, say, for example, a bench press or a squat or even a front squat and looking at other lifts that are going to contribute to it. So say, for example, if your bench press is, say, 100 kilos, then you need your seated military press to be 66 kilos. If you can bench press 100 kilos, then reflectively external rotation on knee should be, say, 10% of what you can bench press, which means you should be doing 10 kilos and these kind of numbers going forward. Have you seen any correlation, or do you have a system to, if I want to hit this is what it needs to be?
No, because I'll tell you what, the very best athletes, the most successful athletes who come and see me are usually the most dysfunctional athletes. Okay, the guy who's going to be bench pressing 230 kilos is probably unable to lift 1 kilogram in the right position that I want to see him in external rotation. Now I can probably get a girl who's a ballet dancer who can lift that 1 kilo, but probably has trouble lifting 20 in a bench. So those numbers don't really correlate at all. What I tend to find though, it's very individual, is that the biggest and the best and the strongest are so dysfunctional usually, quite often, at least the ones who see me, there are the ones who have addressed those dysfunctions and now really move well. But initially, a lot of the ones I get to see are, they might be able to operate magnificently with 90% of the dysfunction that anybody else couldn't move with. And then you get somebody else who's got a 5% dysfunction and can't move at all, it can't hurt, it hurts too much. There's such a thing, I think, with the strong athletes is they don't feel the pain the same way because they're structurally put together, physiologically a little bit different. But it's a really amazing thing to see how dysfunctional top people are, yet unique to make a little bit of difference, and suddenly they're out of pain and they're performing really well. But underlyingly you go, that person's still pretty dysfunctional. Whereas you get other people who aren't very resilient, who it takes a little bit and they can't function. That's why it's such an individual thing. The really great athletes I'm seeing now who have done the hard rehab are now performing and functioning really, really well, and accepting the fact that there were some big deficits that got them to be in pain.
So a hybrid athlete, or an athlete essentially searching for balance. I want to be fantastic at, like say, bench, squat, deadlift, and be able to run and be performing an X, Y. I mean, are we really chasing a myth on that?
Absolutely. You know what? If you want to be a nobody in life, you get really balanced. All right. It means you'll be absolutely shit at everything. If you want to be good at something, something is going to be sacrificed. Hey, the world record bench press holder, probably doesn't run that fast. If you want to be really, really great at something, something is going to be sacrificed. And it might be money, it might be a job, it might be relationships, it's other exercises. But to be the best at something is sacrifice. A balanced athlete is not going to be great at anything particular. They're going to be an amalgamation of a lot of things. So that's what you tend to find. The successful people are only successful.
Have you worked with any CrossFit athletes?
Heaps.
And would you say the most successful CrossFit athletes are either, and this is just my simple observation, either ex-gymnasts or ex-weightlifters, because they essentially started out specialising as something and then went into a hybrid, whereas what a lot of CrossFitters in, say, CrossFit boxes will do is they will try and be a hybrid of everything and then end up being nothing. Is that consistent with what you're saying?
That's where great athletes will still dominate in something. But you'll tend to find that Olympic weightlifting, for example, is such a sport that if you really want to take it up, you better be biomechanically able to move in that pattern. Hip structures are super important. Having the right lever length is super important. That's why you look at who the most successful ones are. They are biomechanically gifted people.
So I know there's people who'll be watching this, probably myself included a little bit. It's like, damn it, I still want to be a hybrid at, I want to be good at, but a lot of things.
Your words are good. You want to be good at it, but you're not going to be great at it. If you want to be great, something's going to sacrifice. You're going to give up something. But you can be good at lots of things, but that's what you'll be. You'll be good. There's a lot of good athletes around. I don't know their names. I know great athletes.
Touche. Yeah. Touche. What's the worst injury that you've seen?
No, it's interesting. The worst injury, it's almost so used to seeing things now that I think worst has to be more defined in upon how it impacts a person's life, not actually, hey, physically this is a car crash look. It's what it depends on a person at probably a psychological level, how it impacts upon their life and how they're going to perform. Because you can see broken bones and people are going to go, yeah, I'm okay, I'll be back. And they do get back. And you can see other people have smaller things which impact greatly. So it's really hard to say the worst injury because most of them seem to come back. If you want to see a nice injury and sort of thing look pretty catastrophic, would be say Jean-Pierre Fuchs, the bodybuilder from perhaps the late 80s, early 90s. There's a nice series of photographs taken in the gym when he tears both his quad tendons off. So,
Well, let me rephrase the question. What's probably the worst injury that you have been a part of and seen, and then been able to successfully rehabilitation? I know in my mind, just to kind of prompt a thought, I remember seeing on Facebook a spine that was pretty battered, and X-ray 1 and then X-ray 2 was a spine that looked pretty damn healthy. I mean, that's one that kind of comes to mind.
Yeah.
What's been the...
Yeah, you could look at those where you can say it looks from a diagnostic point of view very bad, but realistically, is that impacting greatly upon that person? So, yeah, I've seen some really nasty, huge disc problems that have had impact, but people got better with them. And I can remember seeing one fellow who had the most beautiful MRI I'd ever seen, came in, lay down, fell on the bed, didn't get out of hospital for 2 weeks, had the most perfect MRI I'd ever seen. But he had a lot of impact upon his life. There was a lot of things happening at that particular time that influenced how he was experiencing his problem. So he certainly had a biological trigger, but he had a lot of other things that were happening in his life as well. Every human interaction, it's biology, it's psychology, it's everything. But reasonably to me, it's saying, as long as you are, every human interaction we have, if I go order a drink at the bar, it's a psychological interaction. If I shake your hand, it's a psychological interaction. Our interaction with our clients, it has behavioural interaction. I don't get hung up on the behavioural stuff. I work with people, but I'm trying to find out why they're in pain, and I look for the biomechanical trigger. That's one of the important things. That's where physio is getting lost at the moment, is saying, the behaviour is everything. No, it's not. There's a biological trigger that's causing the person to have a behavioural reaction to it.
Folks, you're watching The Wolf's Den. My name is Mark Ottobre. This is my guest, Andrew Lock. We'll be right back after this short break. Make sure you subscribe to us on YouTube for more great interviews just like this one. It saddens me to see personal trainers not earn the income that they should rightfully earn because business is getting in their own way. So there must be a better way of doing it. Have we all been guilty of doing this? It isn't that they can't see the solution, it's just that they can't see the problem. Wolfpack is for that trainer who wants to be that island of excellence that is surrounded by a sea of mediocrity. I've got a client that I pulled from my leads to put on, and I thought it'd be really cool if one of you guys sold it. So who wants to take the call?
Because there's a certain reward in seeing somebody change their life.
One of the most important things you can do all day is when someone walks through the door, say hello. I'm more committed to your excellence and you're committed to your excellence. I want you to remember the pain of being a spectator in your own life. So from training, nutrition, supplementation, to the delivery of the session, to programming, the goal with Wolfpack is to raise the standard of personal training worldwide.
Wolfpack is for the person who's got a goal and a desire to be not just successful at being a trainer, but being at the top of the game. That's what I think of the Wolfpack when I think of it. That's what I think is Mark's objective.
Like an artist or a sculpture, but their art is the human body, is wellness, is health. But you're here for a reason. Is that correct?
Good.
Mark moulds your body from being a broken down fucking wreck that can't move properly to being a machine of love and grace that can do shit.
Hi, I'm Mark Ottobre and welcome to Wolfpack Online.